So, hello everybody. It's now 6:30 and I'd like to thank you for joining us on this webinar. My name is Tina Nicholson. I'm a family physician from Cochrane, and I also have a role as medical director of the Physician Learning Program and the Office of CME here at the University of Calgary. And I'm going to be your moderator for this evening. We'd very much like to welcome you to this discussion around Alberta's Netcare screening status report, and also have the opportunity to discuss the latest cancer screening guidelines. Before we begin, I just want to go through a couple of housekeeping items. If you wish to view a larger image of your presentation, please just go to this area where my cursor is and click that. If you want to exit it, you just click again. To participate in the question and answer session, please simply type your questions into the text area in the chat window and then hit enter. We would encourage you to type in your questions as you think of them during the presentation, and we will be addressing the questions at the end of the presentation. The exception to this is that Dr. Wong has to leave by about 7:15, and therefore we are going to have a short pause after the colorectal cancer screening discussion to allow those questions to be reviewed and answered, and then we will finish the program before every other question is answered. Just a quick reminder, this is an accredited session, and in order to obtain your Main Pro Plus group learning credits and your MOC Section 1 study credits, you must complete the evaluation survey at the end of the webinar. And we'll be giving you those details at the end of the session. For physicians, do remember that if you then go forward and link this to change in practice or QI, you could also obtain additional Main Pro points. Those watching in groups, we obviously have the attendance of one name of the group, but everybody needs to complete that attendance survey in order to get certification. If necessary, you need to email Caitlin, who set you up with your links, with a list of the attendees who were in your group to make sure that everybody gets the certifications that they need. So we're just going to move forward. As you know, this is an accredited program that has been developed by AHF and the University of Calgary. We have received an educational grant from the Alberta Cancer Prevention Legacy Fund. I'm just going to leave this slide up for a minute and not read it all to you, but this is just to disclose any potential mitigating bias. And I'm going to move on to introduce our panel tonight. So Bonnie Chang is a program manager for the Alberta Breast Cancer Screening Program. Christine Couturier is an IT clinical design lead for the Alberta Cancer Prevention Legacy Fund, which is part of AHS's population, public and Indigenous health portfolio. As a health informatics practitioner for close to 20 years, her professional passion lies in the intersection of innovation, technology, positive disruption, and healthcare. Gordon Cleaver is program manager for the Alberta Cervical Screening Program, and Barb Moisey is the program manager for the Alberta Colorectal Cancer Screening Program. And then we have Dr. Clarence Wong. Dr. Wong is a gastroenterologist and medical lead for the Alberta Colorectal Cancer Screening Program with AHS. He's an associate professor of medicine with the Division of Gastroenterology at the University of Alberta and a fellow of the Royal College of Physicians and Surgeons of Canada in internal medicine and gastroenterology. He's an attending physician at the Cross Cancer Institute, the Royal Alex, and a member of the Provincial Gastrointestinal Tumour Group. And finally, Dr. Ho-Min Wang is Medical Director of the AHS Screening Programs and the Provincial Medical Officer of Health for Healthy Living. Dr. Yang has worked in cancer screening area as a public health and preventative medicine specialist since 2006, initially as the medical lead for the Alberta Colorectal Cancer Screening Program and the Director of Screening Programs. And so without any further ado, we are going to move forward to our presentation, and I would like to hand it over to our panel.
Good evening, everyone, and welcome to this webinar on the new cancer screening status report in the Alberta Netcare portal. As learning objectives, participants of this webinar will be equipped to recognize the new cancer screening status report in the Alberta Netcare portal, interpret the screening status report, and then use the report in screening practice on breast, cervical, and colorectal cancers following the provincial clinical practice guidelines. Alberta Health Services Cancer Screening Program consists of 3 programs organized around breast cancer screening, cervical cancer screening, and colorectal cancer screening. And information from these 3 AHS programs is now being pulled into a single report and made available in the Alberta Netcare portal. So this report is called the Cancer Screening Status Report, and it provides a patient's screening status based on his or her individual history applied against the Alberta Top Clinical Practice Guidelines. The status for this report is defined as actionable information. In other words, a recommendation on what, if any, steps need to be taken to get the patient appropriately screened for each of these types of cancer. First, where to find the report in Netcare. So as per normal practice, you first search for a patient in Netcare by using his or her personal health number, name, and or other demographic information. And then once you find the patient whose record you want to view, you'll now see a separate cancer screening folder in what's called the CDV, or Clinical Document Viewer Tree, in Netcare. So the cancer screening folder, which I've highlighted with the red arrow here, will only appear for women aged 21 plus and men aged 40 plus, and who fit the criteria for target populations for routine breast, cervical, or colorectal cancer screening. And there are some exclusions that do apply that we will be reviewing. We will also be reviewing all of the specific criteria in more detail later in the webinar in terms of when you would expect a report to appear in this folder. But as a general rule, if your patient is female, a resident of Alberta, and 21 years of age or older, or if your patient is male, a resident of Alberta, and 40 years of age or older, you can expect to see a cancer screening folder in Netcare. By clicking on the triangle to the left of the folder name and expanding the folder, you will then see a transcribed report called Cancer Screening Status. By clicking on the report itself, you can view the content of the report as per standard functionality in Netcare when you're viewing any transcribed report. One thing to note is that there will only ever be one report in this particular folder. So you can see on this screenshot that some of the other folders contain more than one result or more than one report. But for the cancer screening folder, there will only ever be one report. When a patient's status changes for any one of the programs, a new report is going to be generated and will replace the one already stored in the folder. Some rare exceptions to this rule do apply. So for example, if the patient has a report in Netcare and subsequently requests to be excluded from all 3 screening programs, then the existing report will appear as a cancelled report with the usual strike through on the report name as with any cancelled report in Netcare. Another example that might trigger the cancellation of a report is when a person moves out of province. Since the screening status no longer applies to the patient in the context of the Alberta programs, the information is no longer applicable. If the person moves back into the province at a later date, a new status report would be sent with the previous cancelled report still viewable. When you're in the patient's record in Netcare and you're viewing the cancer screening status report, you might want to refer to the Top Clinical Practice Guidelines. So I'd like to draw your attention to the Resources section of Netcare on the left-hand side of the portal screen. So under Resources, you have a direct link to the Alberta Top Clinical Practice Guidelines website. Clicking on the link will launch the main page of the Clinical Practice Guidelines, while at the same time keeping the Cancer Screening Status Report page open for your quick review and reference. You won't need to navigate outside of Netcare in order to consult the clinical practice guidelines. Now let's look a little more closely at the report itself. So the cancer screening status report contains the following information. At the top you see the name of the report, and right under it you have the date of the report, and this is the date on which the statuses in the report are determined. The date at the top of the report and in the footer of the report will be the same. Next, you will see patient demographics, so you can always be able to confirm that you're looking at whose record you're looking at. And then under the type column are the types of cancer for which the patient is eligible in terms of screening. So this will be breast, cervical, and or colorectal cancer, depending on the age and gender of the patient. Next is the last screen type. So this is the last exam on record that the program has and has used in terms of determining the cancer screening status. So for example, Pap test or screening mammogram. The date of this last exam, followed by the results of each of these last exams. For example, normal. The next column will show you the status of the screening status of the person. So for example, the patient is up to date, is due for screening, and so on. And then a qualifier accompanies the status in the next column. For example, Pap once every 3 years. At the bottom of each report are some reminders around the data limitations of the report and explanations that help the reader understand how the status for each program is derived. So for example, the colorectal program doesn't currently have access to colonoscopy data. So as a result, the status is based on the availability of FOBT or FIT results in the 2-year screening interval with FIT. For cervical, women with a history of total hysterectomy may appear on the report if the woman's family physician has not yet advised the Alberta Cervical Cancer Screening Program of this history. But if the program is made aware of this history, then this woman's cancer screening status report can be updated to reflect that. Finally, at the very bottom of the report, I think it's a little bit grayed out here in this screenshot, but when you're viewing the report, you will have at a quick glance the Alberta Clinical Practice Guidelines for routine screening for each program. So this provides you a quick reference without having to navigate outside of the report itself. As mentioned, screening mammography every 2 years for women aged 50 to 74 years, Pap every 3 years for women aged 25 to 69, and FIT every 1 to 2 years for all genders aged 50 to 74. Now we'll look a little more closely what the data limitations are for the reports and how these impact the reports as they appear in Netcare. Bonnie Chang, the Program Manager for the Alberta Breast Cancer Screening Program, will then review some specific clinical scenarios with you. As we go through the various clinical scenarios in this webinar this evening, we will be reviewing by each cancer to discuss the scenarios, but we do recognize that when you're reviewing the report in Netcare, you'll be looking at all three for the patient. The program recommends that all average risk females between the ages of 50 and 74 years be screened by mammography every 2 years. There are some women surrounding this target population for whom screening may also be appropriate, and these women fall within what we call shoulder groups. For women in these shoulder groups, screening is based on risk or preference in accordance with the clinical practice guidelines. These include women aged 40 to 49 years and 75 to 84 years. You will see a status in the Netcare report for breast cancer screening for these shoulder groups. It's important to understand that these populations are included in the report because they have the potential to be eligible for breast cancer screening and should therefore be assigned a status that provides you, the primary care provider, with guidance based on the clinical practice guidelines and on these patients' individual histories and circumstances. You will not see a breast cancer screening status in the report for patients with a previous diagnosis of breast cancer, for out-of-province residents, and patients who have specifically requested to be excluded from the Alberta Breast Cancer Screening Program. Since the program doesn't track these women, a status can't be provided in the Netcare report. So this slide shows you a sample of what a modified report would look like, where the patient has in fact had a previous diagnosis of breast cancer. This patient is under a different care management stream because of her previous breast cancer diagnosis. So you'll notice then that there is no status line for breast in her report, only for cervical and colorectal. The program is working on bringing these women back into the program in future under surveillance monitoring. Now I'll hand it over to Bonnie to review some specific clinical scenarios for breast cancer screening.
Thanks, Christine. So in this first case scenario, we have a woman who is 52 and she had a normal exam result, so she is up to date in terms of her screening status here. And we say per recommendation of last exam as a qualifier because in some cases, the radiologist may recommend annual screening as the screening interval. And this is because it could be due to breast density and or family history. So you as the clinician, along with the patient, can make the determination about following this recommendation. Okay, in this next case scenario, we also have a female age 63, and she also has a normal result exam from a screening mammogram. But because her last date of exam is May 2015, her status is now due for screening. And then so she's now overdue for screening. So that's what you see there. And then in this next case scenario, we have a female that's 63, and her last screening exam type was a screening mammogram, but she had an abnormal exam. For cases with abnormal results, our goal is for clinicians to ensure that the patient is obtaining the appropriate follow-up. So for this patient, she actually did have a follow-up at the QEW. However, the result was never sent to the program. So we are working on closing some of these data gaps, but it would still be preferable if the clinician check where this patient is at in terms of her care. And in our next case scenario, we also have another female who's 46 with an abnormal follow-up, an abnormal exam. So while the previous case did have a diagnostic follow-up in the Netcare radiology report, in this case, there was no follow-up done that we could find after checking in Netcare. So this is why it's important that the clinician checks to confirm the status. We know that there are times when patients and clinicians decide not to follow up. So in this case, until the patient obtains another mammogram, her status will stay the same here. And then in this next case scenario, we have a female who is 41 with a normal result. However, when you look at her radiology report, you might see that she has an ultrasound recommended. This is due to her breast density. There is currently no consensus around what additional exams patients with dense breast tissues require. Hence, the cancer status report does not capture this additional recommendation, as her result is normal with the adjunctive exams recommended. So it is up to you as the clinician and the patient to determine if the additional recommended test is required. The Alberta Breast Cancer Screening Program is working on providing more information about breast density to both patients and clinicians in the coming months. And so in this next case scenario, we have a female who's 51 with a normal result, but because her last exam was a diagnostic test. And because some women can enter the breast health pathway with symptoms and therefore not considered to be under the screening stream, the program does not receive specific information about what diagnostic test the patient had. Hence, it is listed only as a diagnostic exam. In these cases, it would be prudent for the clinician to actually confirm the result status. And because her listed result is normal, the program will put this patient back into the screening stream based on the recommended return to screen information that is in our system. In this case, that would be May 2019. And at that time, if in addition to another 120 days, if she did not get her next mammogram, then the program will be sending her a reminder letter. And we have another case here where there's a 77-year-old female with her last results that is normal. So given her age, the program will not be recalling her. That is, no further reminder letters will be sent to her. However, if the clinician and this patient deems that there are greater benefits to her continuing to screen than risk, the clinician can continue to provide her with requisitions to get her next mammogram. And lastly, this is the last case. We have an 80-year-old female here whose last result was in 2009 with an abnormal result. We wanted to point out this case scenario because there are a number of older patients in the system with older exams that may not have been resolved in the system. And if the clinician is looking at the cancer status reports of these patients, then it would be good to actually check on these statuses. Okay, Christine, I'm handing it back to you.
Thank you, Bonnie. So now we'll look more closely at what the data limitations are for the colorectal cancer screening statuses and how these impact the reports as they appear in Netcare. Dr. Wong will speak to the guidelines, and Barb Moisey, Program Manager for the Alberta Colorectal Cancer Screening Program, will then review some specific clinical scenarios. So, Dr. Wong?
Thanks, Christine. Good evening, everyone. So I just want to quickly review the current colorectal cancer screening guidelines for Alberta. And then, as stated, Barb will go through some of the scenarios. So as you're aware, the current top clinical practice guidelines available, it's on the top site, it's easy to click. But the main focus of fecal immunochemical testing is on the asymptomatic average risk Albertan. And average risk essentially means no personal and no family history. And so for that group, for men and for women, we target 50 to 74-year-old individuals. Now, some of the shoulder groups are allowed to get FIT, and one of the most common is the 40 to 49 age group. So they aren't considered necessarily average risk, and this section was open to patients that have a first-degree family member over the age of 60. So even though it's open, we're not encouraging normal average risk 40-year-old to do that, except if they have a first-degree family member who's over 60 with a colorectal cancer. At present, as you will see in the reports, the cancer screening guideline is not available for patients with a previous colorectal cancer diagnosis, those who have or out of province, and those who have requested exclusion. The other and probably the most important thing is that patients who've had prior colonoscopy, whether it be in a screening center or as a diagnostic procedure, it is not available to this tab. So as we'll see in some scenarios, this tab is currently based on their last FIT, or even if they've had an FOBT test. But I would encourage you in Netcare to essentially look two sections down from the cancer screening tab, look at operative procedures, and essentially click to see if they've had a recent colonoscopy. And the recommendations on the colonoscopy would actually trump what's on the screen. So I think with that, I will hand over to Barb to go over some case scenarios, and I will be available to answer any of your questions.
Thank you, Dr. Wong. So the first scenario that we're going to look at is a 59-year-old patient. It's a male patient, and you would see this really quick. Well, you see the male here, but you'll note that there is only one exam on here. So if you have not looked at the demographics closely, then you will actually see there's only one report. The highlighted box here is just to illuminate for you that the colonoscopy data is not part of this data set. This was mentioned earlier in the presentation, but this is just to remind you that this information is here for you. In this case, the patient is 59, is due for screening. There is no record of FIT or FOBT on this patient. It is warranted to go back and ensure that there isn't any colonoscopy procedure done, because again, that data is not part of our system. So this patient may in fact be due for screening if there is no history of colonoscopy. But if there is a history of colonoscopy, please do look at the last report and look at the recommendations on that report for further guidance regarding patient status. The next report is a 40-year-old female patient, and this is just as Dr. Wong had just described. We now have a 40-year-old who is abnormal FIT test, which means that blood was detected. The recommendation in the screening report is follow up as clinically indicated. And again, this does behoove you to go back and look and understand whether the patient does have a family history that warrants this. This patient may or may not be a program that would be accepted within formal screening programs, but you do need to look back at this case to determine whether or not a colonoscopy is warranted, and then the avenue to refer this patient on. Most likely it would be to gastroenterology, but some screening programs will accept the 40-year-old with a positive FIT. Next scenario is a 65-year-old female. We now have a FIT normal, which is meaning that there is no blood detected in the sample. This patient is considered to be up to date for screening. However, do please note that Dr. Wong has alluded to this earlier, that the last result is the test that is demonstrated in the surfacing report, in the status report. And what this means is that you do need to look back to find out what the previous exam is, because we're only capturing the last. So in this scenario, this patient is FIT normal or negative. However, if you were to have looked back in the history, you would note that 1 year prior, this patient was actually FIT positive or abnormal in this case. It's important to understand whether this patient actually did have a colonoscopy and whether the previous screening cycle was concluded prior to understanding whether this patient is considered up to date or not. So if the previous test was positive, was never enacted on, it still must be enacted on, regardless of whether the status is normal or not. This scenario is an 84-year-old female, FIT normal. So this is a patient where is considered to be outside our guidelines. These are our case-by-case scenarios where some physicians will accept patients for screening or not. With the screening modality, it is really important to consider length of life and what the risk versus benefit profile is going to be looking like on this patient. So as your patient starts to reach those upper limits of the targeted group, it probably does warrant to have some conversation with your clients regarding whether or not screening is warranted, what the patient's desire for that is, and taking that from a full picture perspective regarding whether or not this patient you would consider moving forward with this patient or not. The next scenario is an 88-year-old female. The patient is FOBT normal. Just a little notation about the FOBT here. As was discussed, you will see FOBT data in our system. However, if you look at the data the last exam, which was 2015, we know that FIT was actually available in our system at that time. So we would have expected in this case that the patient should have undergone a FIT test. It's really important to understand that FOBT data that you see in our system from the time frame of about 2015 up until about mid-January 2018 may be point-of-care testing that should have been done in the hospital setting. We have now stopped feeds of FOBT tests of coming in of more recent procedures. However, this may have been done on a symptomatic patient because FIT should have been the screen of choice for this patient in 2015. However, again, looking at her age, the recommendation would be that she's outside a guideline and probably would not warrant from any further screening here. The last case here is an 80-year-old male who is FOBT abnormal, again done in 2016. Same point as with the previous scenario. This could have very easily been a symptomatic FOBT that was done. The recommendation is to follow up as clinically indicated, and that is just the default. However, clinical correlation is required in all of these cases. And again, it's really important to understand why that FOBT was done. It does not mean necessarily that this case should be referred on for a colonoscopy, and particularly not a screening colonoscopy. This is our last colorectal slide, and I do wonder, Dr. Wong, if you did want to go back over and comment on any of the slides, or if there were any specific questions that the listening audience did have for Dr. Wong.
Barb, thanks. I think the scenarios were well reviewed, and just to show you that when you're reading and going through his reports, that there are a couple of other things to think of, and I think Barb highlighted as well, is that a lot of the FOBT tests are being reported, and they're likely point-of-care tests, and the only places they should be available are in patients in emergency, and I've asked them not to send them to lab and to process them at point of care and then to discard the test. So, as Barb said, hopefully as of moving forward of January, that won't be available. The other key point is that we won't monitor what we call interval testing. So if someone has a colonoscopy, the current recommendations are not to do an FIT, but to look at the colonoscopy report. If the colonoscopy report says next test is in 10 years, that would be the start time of the next FIT. And obviously this panel may not pick up those recommendations. So again, I encourage you when you're looking for colorectal screening, also take a look at the operative report and to make sure that a colonoscopy was not recently done or even in the last up to 5 years. You would have to Netcare click all reports and not just the most recent reports to look at. I think Barb and I would be happy to answer any questions.
So at the moment there are no questions showing. If anybody does have any specific questions relating to colorectal screening and the reports, please type them in now. Otherwise we will continue with the presentation.
So I just see a question. Are all colonoscopy reports uploaded to Netcare by default? So it depends, I believe, on what zone you're in. So in Calgary and Edmonton zone, I believe that all the reports now are uploaded to Netcare. However, in some of the other zones, and some of, for example, in north, central, or south, I think you'd have to go in some ways center by center. So you're correct that box in Netcare may not help you. And in fact, I think in the office, sometimes for those ones, the only reliable source may be to ask patients if they remember they've had screening. The other thing that may happen for those patients that live close to our east or west borders, for example, Lloydminster, if they have their colonoscopy on the Saskatchewan side, they will not show up on Netcare. And so for that case, again, I would obtain that report if possible, and I'd still stick to the recommendation of the endoscopist. So these are some of the complexities of looking to see where the report has been done. It's an excellent question.
Are there any more questions? I was wondering whether there is any plan to show in future iterations whether there is a result history over prior reports, or is it likely that it is always just going to show the latest report?
I can actually take this question. Right now, there aren't any plans to do serial reporting within the system on that. We do always ask that there is clinical correlation, and that would be going back to look at the history of the patient in context of that. That is something that we would certainly, if there were the capabilities to do that, we would certainly consider that for future, but it's our understanding that that's not a potential at this point in time.
And this is Christine, just to add to that, as part of the Netcare initiative, it's certainly something that would be considered in terms of the design and the possibility of having that in future.
And we have another question that's come through just asking how frequently is the report updated?
This is Christine. I can take that question. So the system searches for a change in any one of the pieces of information that could update a status. And if there is a change in the patient's status, then it sends that report. It checks every single day. And so some of those triggers might be, for example, if a patient ages into a particular target population. So if a woman turns 40 years of age, then a new report will be updated as a result of that daily review. And that report will then move from one that has only the cervical cancer screening status to one that will have the breast, cervical, and colorectal. Another thing that might trigger a status update in a new report during that daily review would be a new test result, or a period of time has passed, so that person has moved from an up-to-date status to the past the time period and becomes due for screening. So those are some of the instances that would lead to a new report, but those are looked at daily.
So do we have any more questions regarding colorectal screening? So can we send it back to the panel now to continue the presentation? Thank you very much, Dr. Wang.
Thank you. So last but certainly not least, we're going to examine more closely what the data limitations are for the cervical cancer screening statuses and how these impact the reports as they appear in Netcare. Gordon Cleaver, the program manager for the Alberta Cervical Cancer Screening Program, will then review some specific clinical scenarios with you.
Thank you, Christine. And thank you again for everyone for logging in, taking some time out tonight to come and listen to us about this. We're very excited about this integrated cancer screening report. So for cervical, the main focus is screening on the recommendation risk or age of average risk females 25 to 69 years old, and there is a shoulder group of approximately a few women based on the preference 21 to 24 and then 70 to 84. The reports are not available for patients with a previous cancer diagnosis, for patients who are out of province, or patients who have requested exclusion to not be tracked. Therefore, a status will not be available in Netcare. Women with a history of total hysterectomy may be assigned a status in cervical cancer screening until the program is advised of an exclusionary criteria. There is a delay in approximately 6 weeks for those women who have been seen in colposcopy for that result to show them up. So we also would like to go through some status updates just to give you some scenarios and to help explain what you can expect when you look at the cervical report. So in our first scenario here, we have a lady who is 21 to 24 with an ASCUS result. And the recommendation is follow-up as clinically indicated. So this patient is, depending on if that's the first ASCUS or a second, there may be a different recommendation. So this is due to, the recommendation is due to repeat PAP or referral as appropriate. So we do disclose that we would like you to look at the status and then refer back to the top guidelines. Of course, this recommendation would, in this case, for the 21 to 24-year-old, would ask you to wait a year between testing. Of course, once they hit the threshold of 25, then that decreases to 6 months. So we feel it's imperative just to refer back to those top guidelines because they do change based on the age. So it's an opportunity to highlight for you to look at the top CPGs and also to know that you will, for someone like this, 21 to 24, you won't see a status on the breast or colorectal. Those will not start to appear, of course, until they hit the age 40. And then you will, once they hit that eligible age, then you will see all 3 reports show up in something like this. The next scenario is an unsatisfactory result. So this is a test that went in, and for some reason, the lab was unable to process. So again, the recommendation is follow up as clinically indicated. However, we would like to just remind everyone, a gentle reminder, that we really don't want you to repeat that test sooner than 3 months, as repeating it sooner than 3 months can put you at risk of getting a false negative. So repeating that after 3 months is imperative. And this is a patient who's gone in and had a high-grade result. And so in this case, the recommendation is refer to colposcopy. Again, it's a standardized response under the qualifier due to repeat PAP or referral is appropriate. But again, we want you to refer to the top guidelines. And generally, if this is a high grade, then it needs a prompt referral to colposcopy. The next scenario is a patient who's 48 and who's had an ASCUS positive. So in this case, of course, if you're not familiar, all PAP tests in the province add HPV testing to women over 30 for ASCUS and over 50 with LSIL. And so in this case, there may be, if it's only an ASCUS, then of course it'd be a repeat referring back. But if it's HPV positive, then that would warrant a direct referral to colposcopy. Now, sometimes the lab results, these two results are on two different lines. And so we just encourage you to look at both the result and then for what the HPV status for those women who are over 30 to ensure that the HPV is either negative or positive, and then referring to colposcopy if it's positive. So that's a basic rundown of our scenarios. I'd like to pass it on to Dr. Yang. Do you have any questions? So that really, these tests are an opportunity to inform your patients around the need for cancer screening, and I think it's a great tool to get statuses on all three patients, on all three types of screening for your patients, breast, cervical, and colorectal. And we've talked to other provinces. We had some recent Canadian Partnership Against Cancer meetings with other provinces, and I think we're the only province that puts these three tests together, so we're quite pleased with the ability to inform you with an integrated report. So you have any questions in regards to the cervical cancer screening guidelines or the reports in Netcare? Please type them into the application and into your screen, and we'll try to answer your question. If not, I will hand it back to...
So we have somebody typing right now.
Okay.
The PAP results are just listed as abnormal. Is there any plans to state exactly what the pathology is, i.e. LSIL or ASCUS?
So in this case, currently we just all mentioned abnormal, and so with the clear recommendations based on if the ASCUS or possibly HPV testing or the HCell. But long term, if you think it's important to specify what kind of abnormal in the result, then we can certainly consider this later. But the whole point here is to ensure we understand have easy access to the your patient's cancer screening status information. So so if again you will have lab results also in Netcare. This is just one summary status at the fingertips. So if you still need additional information, you definitely can check on the original lab report.
Thank you. We have another question. Is the interval always 3 years? And an example of what they're referring to is if the latest examination was normal, but they have had a previous HSIL, would the interval suggested be 3 years?
Well, if a patient has previous HSIL, and so for sure that patient needs to be referred for colposcopy assessment and may require some treatment. So if the patient is discharged from colposcopy after quite an extensive period time of follow-up and return to routine screening, so you can still do the every 3 year type of pap test.
Can I just extend that question a little bit? So you say after a period of time for more frequent screening. Can you be a bit more specific as to how long we might need to do an increased interval screening? Say a person had had HSIL in their 20s, ended up with a LEAP, and all pap testing had been normal since. At what point, after how many years, would you recommend that she go back to 3-yearly screening?
And normally when patients discharge from colposcopy, and the colposcopist will clearly recommend a screening interval. And often if they see the recommendations of routines, return to routine screening, then it's every 3 years. And if the recommendations are different, either annual screening for a certain period of time, that recommendation will be clearly stated in the discharge summary.
Okay. I think sometimes we just get told to repeat in a year, and it doesn't help us with ongoing screening beyond that. But that might be something to take up with the colposcopy clinic. We have more questions. Is HPV testing alone sufficient for cervical cancer screening? And is self-swab for cytology equivalent, if not better, than physician collection?
The very good question. I think the answer is yes or no, depends on age. And for women younger than 30, and so you pretty much have a very high percentage of women will have a positive result, and you still have to do a cytology triage. So that's why in certain jurisdictions they actually do testing, and so for us in Alberta we basically do liquid-based cytology. For women with a low-grade lesion like ascus, we will do a reflex HPV testing, and if positive, and then for sure at a higher risk need to be referred for colposcopy. But if negative, it's really essentially considered as a repeat nil result, and the risk of CIN 2 or 3 is very small, very low actually.
Can you see a time when that testing will come in more regularly here in Alberta?
So there's a lot of discussions in Canada right now about using HPV test as a primary screening test for cervical cancer. I don't think there's a definitive answer to that question yet, and so far there's no province actually implement HPV testing as a primary screening test for cervical cancer. I know a couple of provinces considering and doing business case. Again, this is really something we also look into as well, given the HPV vaccination being around for a number of years already. So we potentially can look at the HPV as a primary screen test. But at this time, there's no firm decision yet.
Okay, thank you. I've just got one question on a patient who's had a past history of hysterectomy for, let's say, maybe some invasive cervical cells, but not going beyond the uterus itself. So stage 1. Is there any point that subsequent Vault smears after that surgery can be stopped? And should they be done annually? And if so, for how long? So I think sometimes what's happening is that we will have a patient, as we're doing reminders, who is now maybe postmenopausal and has had that hysterectomy done when they were, 20 years ago or 30 years ago, but they're still within the screening age range. Should we, and maybe they have stopped doing those Vault smears, Is there a firm recommendation on how long to do the Volt smears and at what point it's safe to stop?
Very good question. I don't think there's any trial data available about this particular scenario, and the expert opinions, recommendations, current recommendations, really based on a group of expert opinions or recommendations. So it's a vote smear for life. That's the current recommendation. So it's really a very conservative approach, I would say, but that's just our current recommendation. Of course, this is actually an issue in almost every jurisdiction, and when the new evidence becomes available, we will look into these recommendations again.
And when you say Volt smear for life, are you saying 3-yearly interval?
I think the current recommendation is annual Volt smear.
Annual.
Yeah.
So actually something's just come up which is very interesting. So when we bill for a Pap test in a 70-year-old using a certain billing code, it's declined by the AHS. I guess that raises some concerns if we have these patients, because I know I have some patients like this that have not been having annual because they've had 6 or 7 or 8 Volt smears that were negative, and now I'm going to ask them to go back to an annual screen. So there's that part of it, but also it doesn't actually marry up with our billing codes. And the other piece is that in some of our other data that we can receive, it will be portrayed that we might be over screening, because I'm thinking of HQCA, so that they'll be looking and saying, well, you know, you're screening people over 69, and therefore you need to have a look at that and see why.
In terms of billing, we are actually aware of this issue, and so actually it's not our decision to make. And certainly we raised this question previously with Alberta Health. In fact, the billing is to Alberta Health. So we can certainly go back to have this further discussion again, because this guideline change still requires some additional change to the billing codes, and this will be definitely in discussion.
Lovely. Okay. And there was a couple of comments here about the scenario where a patient either declines to go for screening, or I mean, we were talking actually just before this session started about somebody who might not qualify for screening, for example, a transgender individual who is transitioning from male to female and therefore has no cervix, but because they are deemed female, might show up as being overdue for screening. So is there a forum that we can notify the Cancer Screening Board that this patient is declining or inappropriate? Does that come from the family physician, or is it the patient themselves that would pull themselves out?
So to answer your question, I would say for transgender people with cervix and also ever sexually active, we still recommend they are screened according to the current guidelines. And knowing the evidence, it's really, we actually look for the evidence. It's just the population is small, and we haven't found a good study, but we believe the risk is still there. So we will leave that to the clinician's clinical judgment if the risk is there, and if yes, it should be screened. In terms of how alert the program, I think we like to know that, and so we can as a province to develop a clear guideline policy given based on your feedback. So right now, if you let us know, we will just flag that particular file for further discussion. So and we will look at if in future guidelines how to specifically address those issues. But right now, the general recommendations are transgender people, if they were ever sexually active, and following into that recommended recommended age, and then those people should be screened.
Okay, lovely. There are two more quick questions. One very quickly about a woman who has never been sexually active and is above 25 years of age. How long is it safe to delay that screening if the patient is not keen on going through that?
So cervical cancer virtually is all caused by HPV infection. So if the person never been sexually active, they shouldn't be screened. So for people who become sexually active late, so the current recommendation is 3 years after they became sexually active or older than 25, whichever is later. So you can do the math there. But if never been sexually active, they should not be screened. So there's virtually no risk for them to develop a cervical cancer.
That's great. And then just a final comment. Is there any possibility of there being a patient portal that might involve the patient being able to see their screening status and for them to get?
Yeah, it's really the personal health portal.
Yeah, so is this going to be available for the patients to see? And do you think that might help?
It's in our plan. We like to communicate, to turn the a paper correspondence into electronic through the personal health portal as part of Netcare. There's some technical issues. It's a major barrier for us. We will continue to pursue that. Hopefully in near future that become a reality. A good piece of news is Alberta Health Services Netcare. We also have a patient portal. Hopefully that will be something we can look into. And right now we're in the planning stage. So again, I can't put a timeline there, but it's definitely we will pursue that.
And going forward, is there going to be a forum where you will reach out to physicians to get feedback on how useful they're finding this tool, and whether there are other things that can be improved? Is there going to be a forum for that?
Absolutely. We actually have an evaluation plan, and we will gather the feedback from the user. So really, this is a system developed for you. And if you find this not useful, then that defeats the whole purpose. So that's why we will make all the efforts to make this more valuable to you and also make them more user-friendlier.
I think there's just been a couple of comments here about possibly that it's a little bit too vague. It's just showing the latest result and not the past history, so it might actually increase the time spent on Netcare, and it might be better to just look at the exact result. The other question was whether there's any plans to interface with the EMR providers on this.
Well, remember this is only one of the tools available to you, and then you most likely you already have your own way of ascertaining your patient's screening status. So this is just another tool for you to have. So we really like to hear back from you and get feedback from you how to make this system better. And so again, this system has been developed for you, and we just want to make sure this is user friendly and has added value.
That's great, and I absolutely agree. I think this is it's just another piece of information that might be able to help some of our panel work and outreach screening as we produce these relevant practice lists in our own clinic situations. And I think the opportunity to be able to feed back to you is certainly very important.
That number is very low. We have very few patients who make that decision.
So I look at the last question. Can you review who would start cervical cancer screening at age 21 to 24? I think the issue here is the risk. And based on our surveillance data and actually the surveillance data across Canada, women between the age of 21 to 24 have their risk of having cervical cancers is rare, extremely low. So for that reason, that's the main reason why we don't recommend routine screening for women younger than 25. However, some women prefer to be screened. Their personal belief, their preference, and as long as you have a discussion with your patient and the patient understands the benefits are very small, if any, and there will be potential harms given the transient HPV infection can give you all kinds of abnormal results. So as long as they understand and still prefer to be screened, then that's patient preference. So that's why we say optional. And also people became sexually active very young and also had HIV or other or immunocompromised because of other reasons. You may consider, based on your clinical judgment, if the person needs to be screened early, because if early exposure and also with other medical conditions that affect their immunity, potentially can put them at a higher risk of developing cervical cancer, and also the progression may be more rapid relatively. And so in those type of situations, you may consider screen them early at 21 to 24. Again, that's your clinical judgment.
Can I just ask you a little bit about that? Because we're getting more of the younger population who are started on biological agents, immunosuppression agents for autoimmune diseases, psoriasis, juvenile arthritis. So these are the girls that we might consider if they have been on. I know of a dermatologist who has started somebody as young as 5 years of age on a biological agent for psoriasis. Would that girl then be advised to start her screening at 21, irrespective of whether she'd had any intercourse?
Well, it still need the person has to be sexually active 3 years later before you screen, right. Because without the HPV infection, there's really no risk of developing cervical cancer.
Thank you. Thank you. Another question has just come here in, a little more clarification. So the question is, I am still unclear on how the follow-up examination after an abnormal are posted on this toolbar. So if the patient had an LSIL and the first repeat PAP was negative, essentially on the toolbar you're just going to see that the PAP history is a normal one. So therefore, essentially, we still have to go back and look for the previous PAPs full picture. Is that correct?
Status is calculated based on according to the guidelines. And if someone has a LCO and need to repeat PAP, either younger than 25, repeat every 12 months, or it's over 25 to it's every 6 months. So the calculations based on that. If the first one's nil, and then you still need a repeat, a second repeat. So, but the last test result was really about really the last test result. So
we would expect also that a more detailed recommendation would be on that actual cytopath result that comes into the patient chart.
correct. If you check the Netcare, the PAP test result, we actually clearly give you a recommendation.
And do you think there is any time in the future where this toolbar could show a history? I think we might have asked that before, but could it show more than just the latest results?
Good question. This is a new area we just started, so that's why we make things straightforward. And knowing we only cover the vast majority of scenarios, some specific scenarios we'll never be able to cover in this kind of report. And I think clinical judgment is still very important. And even the status may show, based on the guideline, calculate a status with a recommendation based on the guideline. But you know the patient history, and if you, in your clinical judgment, you decide that additional things need to be done for this patient, I think that's definitely the right thing to do. As a program, we will not be able to make that kind of decision. And so this is, again, it's a more try to cover all the vast majority of the scenarios, and mostly average risk population.
And this is Christine. From a data perspective, if the original abnormal test results place the woman in follow-up status, then and the next results are normal, as long as the woman is continued in follow-up status, the status on the report is, in addition to the normal results, will still indicate that she's in follow-up status.
And would that be follow-up just within colposcopy, or would that be because she's still within a quicker screening follow-up within her medical home?
I think both. For anyone who has a
So it wouldn't
abnormal PAP, the refer for colposcopy. So then couple clinic will do the most of the follow-up, and then before the patient's discharged. And for others, most of the low-grade lesions, and it's really a repeat PAP. We call that follow-up as well.
I see. That's very helpful. Just one more clarifying point that has been brought up, and it's around that question of performing vault smears for women who have had hysterectomies. And it's a clarification of we only do a vault smear annually for life if the patient has had a pathology that was HSIL or invasive CA, or does it have to be invasive, or if HSIL is there, do we have to do this? So just a clarification, because I think this is a really tricky area, and I always think of patient comfort as well, and it gets more and more difficult with the age of the patient, and sometimes we just can't get that pathology because it might have been so many decades ago. So this is a tricky area.
Yeah, it's HCL and carcinoma in situ and also invasive cancer.
Right.
So that
And what
question is
about
correct. Yeah.
and what about endometrial? I mean, is there any, because they have to do faults to see if there are endometrial cells there too. So does that, where does that fit in with the vault smears?
Well, in the endometrial sampling is a different, completely different issue. So for women who have postmenopausal type of spotting, bleeding, yeah, the recommendations endometrial type of sampling or biopsy. So that actually is I think we need a consultation with a gynecologist on the specifics. For the guideline, we just leave that to that high level.
Okay. Just got another one in here, and I hope that clarified things around vault smears for people. So the next question is, on Netcare, is it possible to run a list of a primary care provider's patients that are in hospital? Could it be possible for a similar function to allow providers to run lists of their patients due for screens using the Netcare report? If that's so, it would be helpful for outreach. So I think this is centered around, is it possible to generate panel-related data for a family physician using this result to help us with our outreach work for people who are overdue for their testings? And I presume we're talking any of these screenings, not just PAP.
Christine, you can comment on this. Right now, I believe this particular system doesn't have that functionality. So, Christine, do you have any comment on that technical level?
Well, the system or the intelligence to determine status exists. So this is our first step. There is the potential in future to explore the ability to link this data to panel reports, and that would be a conversation that the screening programs would want to explore with primary care for future panel link reports.
And knowing that there are agencies out there like HQCA that is producing panel-based reports and asking physicians for validated panels, I guess coordinating with an agency like that might be the one way forward.
Right. The data itself allows for it. It's more on the question of the logistics of being able to link the data.
Yeah, we are working with the HQCA. So if you have a panel, and so if Alberta Health confirm your panel, there'll be a panel level type of assessment around on cancer screening, the breast, cervical, and colorectal. So I think we just complete that particular project, and although I don't know when that report will be available across the province. Very quickly, I noticed a couple of questions. One was when this will be, is it possible to connect to the EMR? I think that's a much bigger question. It's if your EMR is connected to Netcare, then this is really, I think you can pretty much use the cancer screening status as well. But if not, then I don't think our one particular group can make that happen. That would be a huge undertaking from for our programs. Other question was more around patient letters correspondence versus physician communication and follow-up. So you still have the primary responsibility to follow up with your patient about the screening and further testing of diagnostic workup. The program here is really play a safety net role. So really to ensure the patient will not fall through the crack, because people do move to a different part of the province. They may move to a different physician. So we are trying to have this safety net, so all the patients will benefit from this.
So patients are notified when their PAP or mammo is due. Are they also notified about FIT now as well? When that, I believe that's right, isn't it? Yeah,
That's
yeah.
correct.
So they now receive, yeah.
The reports, the FIT reports will be updated. They're going to be considered to be due for screening if a FIT has not been repeated within a 2-year mark. And that's actually to give that flexibility of that guideline of 1 to 2 years, and also gives the opportunity for that interaction to be happening in the office in accordance to when those patients are actually presenting to office.
That's great. Can you comment on the 1 to 2 year piece with FIT? Is it? No, it's difficult sometimes. I mean, when we're setting our own reminders, you know, what should we choose? Should we choose a year, or do we repeat after 1 year and then that's okay, move to 2 years after that?
Right. The guidelines are still actually giving that range of 1 to 2 years, and part of what we do know is the sensitivity of the FIT test is such that it is actually giving that opportunity just to say that, you know, we're actually picking up things actually fairly well with that. The other piece about it too is that we do know that patients don't actually hit typical anniversaries of coming in for general physical exams and whatnot. So rather than having everybody in a perpetual overdue status, it does give that flexibility within that framework to do it. New guidelines will be released at some point in this year, towards probably mid-year, and I don't know whether those recommendations on the 1 to 2 interval will be changing. I suspect that they won't be, but I do wonder, Dr. Yang, if you do have any other comments about that.
So we are the only province actually recommend every 1 to 2 years, and so all other provinces and national guidelines every 2 years. Again, the reason, as Barb mentioned, is we know patients will rarely book appointment today and can see a family physician tomorrow. So there'll be some time and you book appointment. Plus, once you get to the lab or to get your FIT test kit, and people sometimes will not do it right away. So that's why it's our, for practical reason, we would say 1 to 2 years. We definitely not recommend any test more frequent than once a year.
Okay, well this time I think I have got the timing right, and I don't see any more questions. I don't know whether any, do any of the panel have any further comments having listened to are there any other things that you would like to relay out to the audience?
So the one thing I'd like to mention is the evidence shows primary care providers' recommendations and probably the most important predicting factor for your patient's cancer screening behavior. So that's why you are not only a gatekeeper, you are also can make sure your patient receive proper care. And so we hope this system we offer additional value to support your practice, but we really like to hear from you and get feedback from you how we can improve. And so this is just a starting point. And other thing I'd like to mention, this actually is the first one in the country. And other provinces actually interested to learn how this works in Alberta before they move to this direction. So your feedback not only can benefit our province, will also benefit other provinces in the country.
That's fantastic. Thank you. Thank you. And obviously, eventually, hopefully it will show a knock-on effect with actual cancer diagnostic rates too, because hopefully that we'll see that going down. So for all those participants, there's just one last message that you might note there from Caitlin, just to remind you that if you've been participating as part of a group, please email Caitlin, and her email is right there with the names of the attendees so that the CME certificates can be distributed. Please fill out the surveys. This really helps towards making these presentations effective. And again, I will say it, thank you so much to all our members of the panel for a very informative session, and for all the attendees for their participation in what was a really good discussion. And we managed to go right the way through to 8 o'clock, so that's fantastic. Thank you very much, and have a good evening.